Hey, Josh.
Hey, just checking in, make sure everything's okay.
Pretty good. I think everything's fine. I just now opened this link, so I need to make sure I let the right people in. I just let in Kristine, and looks like also Matt and Judith. I just seen who was in the waiting room versus who is presenting.
Hi, this is Kristine. Can you hear me?
Hey, Kristine, we can hear you.
All right.
We made it.
Woo!
Hi, Tiffany. Hi, Josh.
Hi there, how you doing?
Doing well. How are you guys?
Hey,
Hey.
Lori.
Hello.
Lori, just real quick, how do you say your last name?
It's Egizio.
Egizio. Thank you. I should know that.
Should you?
Egizio. I always thought it was Egizio. Egizio.
Yeah, it's not something people generally get right on the first try.
There's a lot of ways you could go with it. That's for
Yes.
sure.
Yes.
I made the three of you co-hosts. Do I need to let anyone else in the room right now? Do you have any other co-presenters?
We do not. Judy Howard is not joining us today, so it'll just be the three of us presenting. I have the PowerPoint that I'll pull up, and we have, we're not going to go into great detail in terms of like processing a vignette, but I did send a vignette. But we also have a link just to materials on our website. Tiffany, is it okay if we just pop that into the chat?
Oh yeah, that sounds great.
I think that's probably the easiest to accomplish trainees having access to the materials.
Sounds good.
Okay.
You all should be able to share your screen now.
Yeah, let me just try that real quick.
I'm also going to
Yeah,
make.
and Matt, you're going to drive, right?
Yeah, I think so. I know that when I think it was, I can't recall who walked us through as the presenter preparation session, but kind of insinuated that we would have, passing off of the screen. I think for us, it'd just be simpler for us to navigate with, just me navigating us through the deck, if that's okay. Does that work for you, Tiffany, Josh?
Sure, that's fine for us, no problem. I've put a spotlight on all three of you, so that means that when you're sharing your screen, no matter which of you is sharing, all three of you will always come up. Does that that seem right? Is that the way you'd like it?
Yes.
That sounds good.
Yeah, and I think that was Grayson who you were referring to, who gave that talk from Socio. And yeah, I have not seen anybody else do it that way. It's typically been like you're describing. One of the presenters just manages the PowerPoint and moves the slides when the other folks are talking. So
great. Okay. Well, I should have remembered that it was a Grayson because that's my son's name.
Oh, there you go. Well, we won't tell him.
Yeah.
I will tell you right now, actually, I see the speaker's notes.
You?
Yeah, we're on the next slide and the notes and everything. So.
Yeah, Matt, you got them both up.
There you go.
That's good for you now?
Now it's good.
Yeah.
Okay, I just need to flip my screen then. Okay.
I'll kick us off for just a quick minute if you all don't mind, just a little housekeeping rules before you all get started. And then I have a slide I can show at the very end for the people who are playing the Mind Cans game, and I'll send out the CEU link too, though probably everyone has it by now, but I'll send it out anyway.
Okay, wonderful.
I'm gonna go check in another room. You folks have a great talk.
Thanks so much.
Thanks for checking in,
All
Josh.
good? Yeah, no worries.
So for some reason, Matt, the bottom of the slide is cut off. I don't know if it's because, wait, let me see. No.
Cut off, you're right.
It might be a fit, like there's a thing that says like fit to screen. I can't remember where to find that. Oh, no, you're on. No, you're not.
Yeah, even if I fix the zoom ratio and do fit to window, or even if I make it smaller, like 50%, I still don't see the very bottom. It's not a huge deal, but
I mean, it only matters on that first slide with nothing else written on that very bottom.
Because we have a footer and everything else.
Yeah. So it's just your title that's going to disappear, Matt.
Well, I'll have to live with that, I suppose.
I'll introduce you as Matt the janitor.
That's right. Yes. Our maintenance person. Yes.
Clean up on aisle HFS.
And when you're done with that, get to path.
What's that?
You're done with that cleanup, get to path.
Yeah. There's plenty of cleanup to do. So are you pleased that you're at the end of the week, Tiffany?
I feel like it's been a good conference. We were really nervous about having a virtual conference, just if we would manage all the logistics. We'd never done anything like this before. But yeah, we had a few glitches here and there, but more or less everything worked. So, and the presentations have been really amazing this year. So exciting. It has been a busy week though. I'm going to sleep well tonight.
Yeah, from a participant perspective, I think that it's gone quite well. We've had a lot of good sessions and had some interesting dialogue. So I think it's a success considering the circumstance.
And I can't believe we still have 14 people hanging in there till the tail end of this thing.
Yeah, right.
They need extra points.
Yeah. The game when I was losing by like 1,100 points.
Right. Yeah, I went to the leaderboard. Like, oh yeah, okay.
I know.
Not that
Like,
invested.
how did people get 1,000 points? I thought I was I'm at like 200.
That's priceless.
I haven't been playing, but I'm glad to know that it's turned into a competitive sport.
Yeah, there are some serious there's some serious folks out there.
Now, what the heck did I miss? It sounds like fun.
Well, they've put together this mine cans, which are you familiar with Minecraft at all, Kristine? The video game? Heard of it? So basically, when you complete a course or a training, a presentation, you get little clues that you can enter into to get points and presumably win some sort of award or be in the running for some sort of award. And so I was just putting in completion of the, presentations that I attended. It was just like 20, 30 points per presentation. And all of a sudden you look up and people have like 1,400 points. I'm like, I guess I didn't fully understand the full scope of the rules.
Maybe they were stealing points from other participants.
Yeah,
you never know.
Well,
Could
there
be on
were
black
points.
market for points.
Yeah, there were points for going to that little comment section, that messaging section. So I was even doing that. I was like, ooh, I can get points here. And I'm like commenting and all kinds of things. And then I go back and I look and I'm like, where are these people? 1,200 points. I don't know.
Hey, it's still on the presenters version. Is that what you wanted for right now? It's the I'm looking at the presenter.
We're still seeing notes
with the notes.
You're seeing notes again?
Yeah, Matt, you've got it on the split screen.
Yeah, I do that too sometimes.
Mm-hmm.
You don't want to give away the secret sauce, man.
No, I know, but what did I just do?
It's going to be returning, switching your display again.
Yeah.
Your display settings.
What on earth?
Can you all see me when I talk, or did my spotlighting you?
I can see you, yeah, but
No, I don't see you when you talk.
Oh, strange. It won't let me spotlight myself, even though I'm pretty sure I did that.
But I am
There.
not quite display settings.
Right there. That's what you need. Swap. There you go.
That's perfect.
Okay. It's still cutting off though?
Yeah.
You're still the janitor.
Yeah, I'll live with it.
Do we want to stop sharing for just a moment so that we can let people in and they can see one another for just a minute? Or will that mess up
Yeah, I was gonna say, it might mess me up again here, Tiffany.
That's okay. We can just leave it like that if you want. That's just fine with me.
Okay, yeah, I guess I would probably prefer to leave it because I don't trust myself whatsoever.
All right, let's do. Are you ready for me to go ahead and start admitting people?
Sure, yeah, that's just fine.
I'll give them a moment to get settled. If people need time to get settled when
But then we don't get to see,
Zoom.
we don't get to see any of the people come in.
If so if you're using only one screen, the way that you can see everyone coming in is, so the way it looks for me is I see you all as presenters being spotlighted on the right, and then I see the slide deck on the left, and there's actually like this little bar between the two that you can slide. And so if I slide to the left to make your presentation,
Yeah,
I can see all of your images.
but that's not showing me you, so I'm assuming it wasn't going to do that.
Yeah, that's weird. I don't know why. I may remove your spotlights for just a minute and then put them back in once.
Oh, you know what? If you do view in gallery, you'll get everybody.
Here we go. That's right. Thanks for teaching me how to be a moderator.
Say that again.
The right-hand corner, it says view. If you switch it to side-by-side gallery, you'll get everybody.
I think that's what I had, but okay. Well,
do you have Tiffany on your screen right now?
I have Tiffany, yeah.
Yeah, then you're on gallery.
Okay.
Right, I'm going to admit everyone. Well,
Okay. And the screen still looks okay?
Yep.
Looks great.
All right.
And it's actually not cutting off anymore either now with the gallery.
I stopped duplicate. I stopped split screen.
Oh,
So
okay.
maybe that's,
Oh.
as long as it looks good on your end, I think I'm about as good as we can be.
Yep.
Yeah, that did the trick. It's great.
Looks like our team's here.
Yeah.
Welcome, everyone. I'm Tiffany Lindsay. I'm your moderator for this session. We still have a few people joining, so we'll wait just a couple more minutes. All right, that was maybe the shortest couple of minutes that's ever been had. It is 4:05 my time and Eastern time, and looks like just a couple more people were in the waiting room, and I've let them both in. So I think we will go ahead and get started. This breakout is for CEUs, so I will drop the link into the chat box, but I'm sure that most of you who have been gathering CEUs already know this link because it's the same link for all the CEUs. You can always just complete the survey once if you like, but you'll need to do it for each session that you attended. So one survey link, but all the different breakouts are there. And so you'll complete the survey for each one that you've attended. And I think that's all. I'll go ahead and turn it over to our presenters.
Thank you, Tiffany.
All right, fantastic. I'm sorry, Matt, go ahead.
No, go ahead. Go for it, Kristine.
Okay. Passing the ball in the virtual environment, right? So welcome, everyone. Thanks so much, Tiffany. I understand that it has been a fantastic conference so far. Unfortunately, I haven't had the chance to participate much, but I understand that both Matt and Dr. Egizio have been desperately trying to find points and have come up a little short, unfortunately. So I don't think they're taking home any awards, but it does sound like it's been a really great conference. So I'm Kristine Herman. I'm the chief of the Bureau of Behavioral Health for the Illinois State Medicaid agency called Healthcare and Family Services. And I'm joined today by our fantastic team of CANS experts and trainers, Dr. Egizio and Matthew Stinson, who are going to cover the more operational aspects of the IMCAT, or the Illinois Medicaid Crisis Assessment Tool, and how that tool has been integrated into crisis safety planning in Illinois. And it's really resulting in an enhanced clinical foundation for crisis safety planning, and certainly for more effective interventions for the customers that we serve. So Matt, you want to go on to the next slide?
Sure. You want to talk about that at all, Kristine, or just kind of?
Yeah, I actually do. So before we get too much further into the presentation, I really wanted to highlight the partnerships that we've developed to support the rollout of the Illinois Medicaid Crisis Assessment Tool. Healthcare and Family Services established an agreement with the University of Illinois to utilize resources within the School of Social Work to create the Provider Assistance and Training Hub, or commonly known as PATH. And Dr. Egizio and Matt are both associated with PATH. So HFS and PATH have worked very closely with Dr. Lyons and Dr. April Fernando to develop the IMCAT and the training that PATH is providing. So through these partnerships, HFS is building a very strong foundation for the provider training and technical assistance that will sustain the behavioral health system enhancements that we are working on statewide to implement. So Matt, let's go ahead and go on to the learning objectives. Okay. So we do have a few learning objectives that we wanted to achieve through this particular session, and you all can let us know how close we came after the meeting is done through the evaluations. Hopefully they're positive. So we want to give you some of the background about why we decided to go down the road of combining the crisis assessment tool into crisis safety planning. We also want to give you some background on the context for creating the integrated tool and where we're at in the implementation process. And then we want to discuss how the integration of the crisis assessment tool helps staff provide more effective crisis stabilization and communication among provider partners. So lofty goals, but I think that we can do it. Next slide. Okay, so we're going to start with our first two learning objectives that were highlighted on the last slide by talking about the context under which we decided to begin utilizing the crisis assessment tool. So as you can see here, HFS began the process of developing the IMCANs as a key ingredient to a larger transformation of the state's behavioral health system a few years back. This transformation involved a large collaborative effort between several child-serving agencies in Illinois and Dr. John Lyons to develop an integrated assessment and treatment planning tool called the Illinois Medicaid Comprehensive Assessment of Needs and Strengths, or the IMCANs. The tool is based on both the CANs and the ANSA, making it a lifetime tool that can be adapted through modules to allow the assessment of needs and strengths across the full spectrum of Illinois' Medicaid population. So this offers Illinois standardized assessment and treatment planning data that previously did not exist. This standardized lifespan assessment process creates the foundation for the other enhancements that Illinois will be implementing. Illinois also wanted to enhance the mobile crisis response system throughout the state for Medicaid eligible individuals and utilize the IMCANs as the basis for the crisis assessment tool, or the IMCAT. So this provided consistency between the lifespan assessment and the crisis assessment, so it made perfect sense to carry that consistency through to the crisis safety planning. This process also helps to reinforce the continuity between the assessment and the treatment planning process and the crisis response and intervention. And that keeps the strengths and needs of the person at the forefront of each of those processes to maintain that person-centered care and to enhance engagement. So can we go on to the next slide? So I've referenced this part a couple of times, but it really bears repeating. HFS is a Medicaid state agency, and we are continually looking for ways to enhance the overall clinical standards of the behavioral health system, while also improving access to services for our customers. To accomplish this, we knew that we needed to provide ongoing, consistent training and technical assistance to our provider base. And that's really why we developed PATH, to support the effective implementation of both the IMCANs and the IMCAT, as well as to assist with the training and other clinical services offered in Illinois. So I'm really happy that you're going to get to hear from two of our team members over at PATH. And with that, I'm going to hand this presentation over to Dr. Egizio.
Thank you. All right, everyone. So now we're going to kind of dive into what is actually our, predominantly our crisis safety plan. So we start first with just recognizing that we're utilizing the IMCAT. And part of our mobile crisis response event is really utilizing that CAT to build our crisis safety plan. So in the state of Illinois, we do require that our mobile crisis response is a face-to-face. At least that is generally our goal. In this time, it may not always be reasonable or happening, but often we always want to make that a live face-to-face event when we can. And so at that time, that is when we are going to be utilizing our IMCAT and then moving that into, moving that information over into building our crisis safety plan. So our crisis safety plan in Illinois is part of Rule 150 and is required. Most of you probably are familiar, but I do want to just share that the CAT does include domains such as risk behaviors, trauma exposure, so those ACEs, those adverse childhood experiences. We also have the behavioral emotional needs, life functioning, substance use, developmental disabilities, and cultural factors in the CAT. And those are the components then that we utilize, as well as some additional information to move into building the crisis safety plan. So just taking a look at how this all kind of works and plays out. Our CAT, we use it to build and to organize the information that we gather from the assessment. And so this guides our decision making by really exploring those needs and how to keep the clients and others safe. And so we tie this back into TCOM, always utilizing that collaborative approach. And predominantly, we want to make sure that we're doing that because just because our clinician really has to have that understanding of what brought the client into crisis and ultimately what occurred during crisis, and then how do we move forward? How do we make this a more useful or a less crisis likely event in the future? And so this really can only happen if we're building that trust, and that generally involves that active listening and beginning that with that engagement process. So when we're helping our providers begin the process of understanding the CAT as well as understanding our crisis safety plan, we want to make sure that we're really exploring the engagement process and the benefits of remembering that this begins immediately and the ultimate benefits to building that collaborative approach right from the beginning. So like I said, we do use the IMCAT data to inform our crisis safety plan. And our crisis safety plan is a standardized crisis safety plan. And it does begin that process of creating a stabilization plan, which is intended to be used at the time of the crisis, as well as during any follow-up services that we're going to be looking at in the future. So both the IMCAT and the crisis safety plan will be used to inform any follow-up providers. And this will be done by helping the follow-up provider have access to those identified needs at the time of the crisis, as well as any information that can be used to update or initiate an IMCANs that may take place down the road. All right, any thought, I know I didn't really go into the CAT, but any questions or thoughts about how our IMCAT exists or how it's used? I will talk now about how it generally builds our crisis safety plan.
This is Barbara Dunn. I just had a quick question. So is the CAT pretty standard in, like New Jersey has one, other states have one. Is it pretty standard, or did you name it the IMCAT because it is so different?
I'm going to throw that at Matt.
Yeah, sure. So, the Illinois Medicaid Comprehensive Assessment and Needs and Strengths is the Illinois version of the CANS. And so it does use a lot of the, core 50 CANS items and the ANSA items, some of the ANSA items that Kristine was referencing earlier. The Illinois Medicaid CAT does communicate more specifically with the Illinois Medicaid CANS. However, my understanding is that a lot of those items are utilized in CAT products across, other jurisdictions and systems.
Thank you.
Can I add something since I happen to be here?
Yes,
Yeah, Barbara, the main difference with the Illinois version is that it's actually a lifespan version. So most versions of the CAT are actually child versions. So that's why this one has some of the adult items in it. But the child items are going to be pretty similar to most other versions of the CAT around the country. There are some differences. That's why Illinois customized it to be its own tool, but you would recognize that it looks pretty similar to other ones.
Yeah, it does look pretty similar, but yes, that's true. This is the lifespan. I see that now. Thank you.
Thank you, Lynn. Okay, Laura, you ready to move on?
Yeah, real quick though, I just want to share that I did throw in the chat box our Illinois documents. So if you want to look those up, you can grab that link, and we are going to be using the vignette that you find in there. This is the vignette that we use to train all of our providers in Illinois. It really won't be necessary for you to read it intensely, but just to have an understanding that that's where our examples are going to come from that we're going to be sharing moving forward.
And Barbara, our version of the IMCAT is in that file as well.
Yep, I have it pulled up.
Wonderful.
And we're going to pull those up on the slide here too, so you'll be seeing them as we move along because they are actually in our crisis safety plan. All right. So this just really lists out the components of our crisis safety plan. And just to kind of bring to your attention some things that we're going to be talking about, we're going to talk about the crisis descriptions, identified needs, which that's going to really be, like I said, that crisis safety plan. We're going to then move into talking about triggers, risks, coping strategies, strengths. Then we'll go over the goals for our crisis plan. So really just looking at that crisis event. And then just the authorizations and such after that. And so I don't think I actually mentioned this piece, but the crisis safety plan that we're going to present to you today is the one that we sort of recommend. It's not mandated in the state of Illinois, but the components that are in it are. So we'll use it as our hopefully beautiful example for you. All right. So our very first section that we're talking about here is what you see in front of you. It is describing the warning signs and problem behaviors that sort of led to the event that we would be working with the client in. And so we just like to remind people that the crisis is a series of behaviors that has resulted in an increased risk of harm to the client or others around them. And so to safely plan for a crisis, we must really first be able to identify the crisis. And that really involves all of the collaborative people, all of those supports that are in the client's life, and helping to gather an understanding of how they view the event as well. And so we like to have sort of some questions that might be useful to gather this information. So whenever we come to these slides, I'll share with you the questions that we recommend that providers have access to gather this information. Because remember, this is a conversation. So we're really trying to encourage the providers to have access to the questions they would need to gather the information. And so some of these questions might be, what behaviors are signs that a crisis may soon occur? What physical signs can reveal that the crisis may be beginning to happen? And so again, these are questions we might be throwing out to both the individual in crisis as well as their support system. Some more might be, are there specific situations that led to the crisis? Describe the crisis behavior or situation in detail. What's happening, including verbal or physical aggressive behaviors, suicidal behaviors, things along those lines. And then we're going to sort of pull that all together, and we're going to do our very best to use the individual's language. And so you can see in here, like I said, we're utilizing that Araceli vignette that is in the documents that are part of that link. But obviously, some of this information isn't actually in there. So we would say that we're sort of building on it, having some additional conversation. So some of this you may not see very literally in that vignette, but we would pretend that the things here in quotes, our individual Araceli did actually say these. So we have completed this box by saying, it seems that everything is spiraling out of control for me. My husband is cheating on me again. We were previously evicted from our last apartment and we're homeless. Now DCFS has placed our kids with his parents. And those are in quotes. And I believe those are actually in the vignette. So those are things we pulled out that Araceli did actually say. And then we had to live with my cousin, and now she's kicking us out due to the argument. I lost my job and have not found anything new. I just felt like ending it, so I went to get some rope and hang myself. And then it seemed like a good idea for a while this morning. So that's the problem behavior, right? That's the crisis event. That's sort of what ultimately landed us here. Does that make sense to everybody? Do you have questions about how we've built that information? All right, so the next one that that exists within our crisis safety plan is this category of needs. And as you can see, this is just, what does Araceli need at the time of crisis? So, or even before the crisis. So what are the needs that she would say would be helpful for her? And so some things that we would ask of Araceli are for her to list what, who, when, and how often need as a support. And then what is the benefit to the behavior? So this is really to help us have an understanding of why this behavior is occurring. And generally that means there's some type of need that is not being met. And then what happens as a result of the behavior. And so again, we want to emphasize that we're going to be using the individual as well as caregivers or support people's language here. And so what we've gathered from Araceli is I need the following support when in crisis. So talking to a friend or a family member, talking to a counselor who can easily be accessed, and then also the opportunity for time alone to calm down. And so you'll see this again a little bit later, but this might be a great place to really specify the names of those support people, phone numbers, things along that line that really could be useful for her when she is in that moment of crisis. All right, so the next portion of the crisis safety plan, this really is exactly what I was saying before about a piece of our IMCAT. And so this just gives us the opportunity to make certain that we have this supporting information accessible to both us as well as the individual. And so when we're talking about these behavioral emotional needs, a couple of things that you can see here, and obviously if you have or have not read the actual vignette, we've just documented here from the CAT exactly the areas that we'd like to focus on. So, or the areas of needs that she would focus upon. So you see the depression there, you see the anger, frustration, and then the substance use. So if you're reading the vignette, you would see some of these things that we have here in this supporting documentation. So the prescribed medication isn't being taken, the suicidal thoughts, not sleeping, weight loss, irritability, those kinds of things. And then Araceli stating that she knows that she has problems managing her irritability and her relationship with her husband, that kind of thing. So this is just directly from the IMCAT. It just is helpful to have it present as we're building the crisis safety plan. All right, and then again, looking at a component of our IMCAT as we're building the plan. And so we do use this section really to remind the trainees that we will be rating the items that are relevant. So when we're presenting this to our providers, we just like to make certain that we bring to their attention that especially during a crisis, there are categories that there are items that we may not really be able to have a discussion around, but just having an understanding that the things that are on the forefront of a crisis, we make certain to demonstrate here. And so again, you can see the supporting documentation that Araceli and her husband are at risk of being evicted from the cousin's home. Just some of the relationship difficulties, the fact that they've been homeless, and then just that she hasn't been compliant with her medications and is not sleeping.
You all do have a couple of questions in the chat.
Yes, yes.
Hey, Lori, no, I just saw them. It says, so Juno says, who's reviewed it? So is this system or human identity for the behavior problem? And then Barbara asked, is it only on paper?
Yes, currently because this is not a mandated document that providers have to use. It's just an example of a manner in which you can integrate information that is collected through engagement processes into a tool like this. It is currently just an electronic version of this. I don't believe that this exists anywhere else other than our website for the time being. I hope that answers the paper question. I'm not exactly positive who is identifying the problem behavior or concerning presenting behavior. Is that the question?
I don't know if Gina wants to clarify a little. I'm not sure either. That is the way I interpreted it, Matthew.
Okay. Yeah. So I mean, typically we believe, right, that the individual identifies what their crisis is. A crisis can be very different for each of us. We may be experiencing something similar. I may consider that a crisis, and I may need additional crisis support, which would initiate a mobile crisis response event. Kristine, may have something similar going on in her life, that she has other supports, resources that doesn't constitute rising up to the level of requiring a mobile crisis response event. And so we do determine, the individuals determine sort of what is a crisis, but how we would come to some consensus would be, through that engagement process when we are meeting individuals in the home, in the community, out in the field to provide that crisis support. And so that's a collaborative effort to engage with the individual that is experiencing a crisis or identifying a crisis to understand from their perspective what the concerns are. We do have a system in place in Illinois that allows for an individual to call what's called a CARES line. That CARES line does a very brief acuity assessment and it determines whether that rises to the level of requiring a mobile crisis response event, at which point a designated provider responds to that individual in crisis wherever they are experiencing that crisis. So, it is not for a provider to identify the crisis. I mean, of course, there are times where in the field, we may be the ones that identify someone is in need of some additional support, right? But it is really ideally an engagement effort for an individual to identify what a crisis is.
Are there any other move further? And did that answer the question?
I hope that answered.
All right.
All right, I think I messed up our.
So we should be on 16.
Slide.
That's right. We're good. All right, so the next component then of our crisis safety plan is looking at these risk behaviors. And so what we're really trying to gather here are what risks exist in the environment. And so some questions that might be helpful for our providers to ask are things like, are there certain words, peoples, places, situations, or events that trigger this behavior? Some other things might be, what are they and how often do they affect the situation? And then under what situations are things better or less likely to occur? And does this include some people? So are there support people that we can pull out of here that might really be able to help us to build our crisis safety plan moving forward? And then when does this behavior not happen? So what's going on in the client's world that when the behavior is not occurring? Are there other supports that might represent for us? And then just to utilize these answers moving forward and understand, we'll list them here and we're going to again use client language as best as we possibly can. and then have access to these as we look to build the supports down the road. So from our Araceli vignette, sorry, can you go back real quick?
Oh, sure. I'm sorry.
From our Araceli vignette, you can see that she has mentioned that there's obviously risks present when she and her husband are fighting. And then obviously with the cousin's inability to feel safe with them staying in the home. And then obviously acknowledging that there was a homeless issue in the past. And then we look to mention here the use of marijuana and the loss of job. And then her comment that she just doesn't feel like she can take it anymore. So those are the risk behaviors that we listed here. All right, and then this is directly from our IMCAT again, so you can see the items listed there, and just making certain that, again, that we acknowledge that the most predominant crisis items are present when we're talking about risk behavior. So in this particular case, we're looking more at those suicidal risks, that suicidal ideation that existed within the past 24 hours. And then we also have some questionable decision-making here. So we have mention of that, just her not taking her medications, the substance use, that kind of thing. But then also acknowledging here that she is seeking help. So, all right. So our next category then is looking at starting really to build those, that plan as far as the future. So we have here this category of cool down or coping strategies. And so this is just like it sounds, you know, what can we do to be able to avoid the crisis? And so we really like to express that although you can utilize a narrative approach in here, this box also kind of lends itself to sort of these dot points, which is the way we've drawn up this one. And then again, just iterating the importance of using client language, especially on this box, because this is where the client is going to really be able to pull that up and say, okay, what do I do? What are my coping skills? How do I utilize them? And so we want to make sure that they are in Araceli's language. So some questions that we might be asking to gather this information are things like what steps or goals are needed to prevent the crisis, like who, when, how often, excuse me. Are there things that can help better the situation? And what could have been done instead? And so then obviously some of the things that Araceli may have said are, I could stop and take note of my body, mind when she's feeling overwhelmed. And this next one I really like, the idea that she would knit. And this really just demonstrates the use of the collaborative efforts and utilizing Araceli's own language and allowing her to share with us what might help. By no means would I put down here knitting for other people unless I've heard that from Araceli herself. And then we have mention of journaling, breathing, taking a walk, getting away from the situation. And then ultimately the reminder here to revisit this document and be able to just remind her what she's working for and these kinds of things that are going to motivate her, like getting a job, getting her apartment, getting her kids back, that kind of thing. That makes sense to everybody? All right, so then I kind of jumped ahead there a little bit, sort of addressing this help box. The pieces that we're going to be looking for here are just those people that she can call upon. And so we mentioned some of these a little bit earlier. In talking about, you know, who are the people that can make the situation better for her. And then just bringing up the fact that we want to make sure that we include both formal supports and informal supports here. So that's why you'll see here we have the cousin, we have her friend Kathy. So we're making the assumption that we have had a conversation with Araceli, and she said that yes, Kathy's a person who helps me when I'm struggling. And then also just a call or visit to the clinic. So we make ourselves accessible to her. And the other thing that, as I was saying back on that box number 2, this is where we see these names popping up again. And I think an important piece here would not to just have visit my cousin, my friend Kathy, but also to have some specifics. What's the cousin's phone number? What's Kathy's phone number? Although it's probably saved in her cell, but we might want to have our phone number down there, the clinic's address, whatever it might take, so that when she looks at this, it's right there. It's for her to be able to move in the direction of utilizing her help. All right. So this next piece here is this caregiver resources and needs. And so for those of you who are familiar with this from another CAT or CANS document, you'll know that this is utilized for children or anybody, minors or adults who have a individual in their life who functions as their caregiver. And so with Araceli, we don't have anybody here, so this section would just be left completely blank. All right, so I think this is sort of the bulk. This is, aside from the coping skills, this is some of the really important information, sort of the meat of our crisis safety plan. And so there's several pieces that we have here. And the first one that we're looking at are her strengths. So what strengths and resources can she use to manage a crisis in the future? And again, looking at, we're using some of this client language here. Emphasizing that they can draw upon their strengths to cope in the future. What you see here are quotes. So we have Araceli's language. I really want to get my children back, make big life changes, get back into counseling, taking medications, and then utilizing her support systems. So just really acknowledging that these strengths came directly from Araceli and helping her to begin to see that she has these positive attributes within her life. And then the next portion is this things of importance. And so some of these sections here, these two in particular, we may see some overlap, but these are the things that are important to her, right? Her family, her support resources, that kind of thing. And so some of the questions we might be asking here are, what do you find rewarding or fulfilling? What's important to you and your family? And what can she do? What can be useful for her in the future as far as reminders when she's falling into those patterns of crisis behaviors? And so this box is really what we like to consider sort of leading into that shared vision. And so if you're familiar with that shared vision component, that really is that sort of that magic question, you know, what if you could have anything, what would your world look like? And so understanding what's important to her, what would her world look like? What is her shared vision? That's really how we can build the components of this box. And so for Araceli, she said things like, my family's important. I want to focus on getting myself better. Emphasizing her children again, and then just recognizing that she wants to work things out with other family members, and also that aspect of getting a job. And so this is really just acknowledging those things that she's striving for, why she's putting forth these efforts. That makes sense? All right, and then this next section are her service preferences. So this is important to ask her about what has worked in the past. What has made a difference in her life before? How did it work? If it did not work, what were some of the challenges? And just having an understanding of how we can learn from past efforts and what it is she's striving for in the future, what she thinks will help her down the road. And so with Araceli, we're gonna pretend that we had this conversation with her and that she's saying that she prefers a female therapist because she's had male therapists in the past and they did not make her feel comfortable. And then just understanding this medication piece, I think this was really important. She stopped taking her medication and here she's acknowledging the reason why. They made her feel weird. She wants to make sure she has a doctor who listens to her. And so that may have stemmed from a conversation of not having that supportive doctor in her life. And then she's gone to group therapy before, liked it. and enjoys being around other mothers. And those are good role models, right? So we want to make sure we write these pieces down. We're not saying that all of these are available to her or that we can guarantee these things are going to be present for her, but just having them there so we can start to have that conversation as we move forward in building her plan. All right, and then ultimately these are the goals. So we're looking here into what might be present as far as follow-up sessions. Excuse me. Again, writing these in client language, we want to make certain that she has access to this and she can just pull these out, read these, and they're almost directions on how to help to support her. And so as you can see here, the way we've written this crisis safety plan, this particular goal is acknowledging the I am CAT items that we're incorporating in here. So for this particular one, it's suicide risk and depression. And then what we are hoping to have her do in the future or to help her to do in the future. So we're looking at this from a crisis perspective. So keeping that in mind that these are going to be some short-term goals. And another thing that we like to really emphasize is not making all the work part of Araceli. So you'll see the first goal here, or the first objective is Araceli will start to recognize when she's feeling overwhelmed and use those coping skills. But then the next one incorporates some of the support people into her life. So the next one is my mobile crisis responder and I will meet tomorrow. So obviously we've scheduled that appointment and start to understand how we can work on those med management, the substance use services, counseling, things like that. But we're really putting this emphasis on not just Araceli, but another individual. And then this bottom one here is for her to reach out to her support people to manage her feelings. And then also, like Matt mentioned earlier, we also make certain that we have this CARES line in here. We don't want that to be her only goal. We don't want her only option when things are not going well, call the crisis line. But we do want to make sure that she has access to it. And again, making certain that that number is here for her. And then ultimately, we have a second goal written in here. Again, acknowledging the CAT items that we're going to be addressing. And then again, as you can see here, having some of these tasks put on other people other than just Araceli. So my DCFS caseworker and I will meet Friday. And then the second one here is I will talk with my cousin within the next 3 days about continuing to stay at her house. And so, and working with the treatment plan also, a treatment team. And so you can see this puts a little bit of something on her, a little bit of pressure, but to start acting gives her a little bit of time. But ultimately, we really only have 2 tasks for her within these 5 objectives. So we make certain that we have other people supporting her and beginning the process too. Does that make sense? Any questions about those pieces before we move forward?
I really like how you've got this set up. I mean, it just seems very fluid.
Good, thanks.
Thank you.
All right, Matt, you can talk about the next one?
Yeah, I will. Prior to moving into this piece, I just really want to, kind of reiterate a few points that, when we're talking with providers, the individuals doing this difficult work out in the field, that part of the struggle is becoming very prescriptive or implementing or deploying a document or a tool like this. The same struggles or challenges that we have in using CAT and CANS, that those suggestions that Lori provided to you about types of questions that might be helpful in gathering that information, that we really are focusing our efforts and attention on engaging and hearing the individual's story and what's brought them into crisis, the same way we would when we're talking about doing a mental health assessment and treatment plan. And so it's really about hearing their perspective or collateral's perspectives to get this information. And as any of you on this call know who've done crisis work, you don't receive all that information at point of crisis for a variety of reasons. And so this is an example of how we've maybe progressed through additional inquiry and listening to collect this information. So obviously we're taking a little bit of liberty here and saying this is a sort of an ideal situation where we have information about Araceli and we were able to successfully collaborate with her and Kathy to get some more information and supports to put into place for her. But one of the things that we really want to emphasize is the idea that is our priority, is to engage and to hear perspectives, as opposed to simply walking into a crisis event to simply just check off boxes, do mental status evals and risk assessment. We are trying to turn the corner to becoming a more collaborative in our efforts at that point of crisis. So again, this is not a chronological document that you pull out and work through section by section. We obviously go through it section by section and detail that so that we get a little bit of that information out there to our trainees. However, we do emphasize as well that the reality is that's not how we collect information. It's just not a collaborative approach to do so. So just want to throw that out there. The final piece of this, and something that's unique in Illinois, or at least I believe it's unique. It's unique in Illinois because it's relatively new, is the ability for us to authorize a service, a Medicaid service of crisis stabilization prior to the completion of the IMCANs, or what would serve as our mental health assessment and treatment plan that would open up the full Medicaid service array. And so in this instance, we've created an example of what might be included for a licensed clinician in the state of Illinois. You'll see LPHA, Illinois, that's licensed professional of the healing arts, typically your LCPCs, your LCSWs, your RNs, so on and so forth. These are individuals that can, after review of a crisis safety plan that Lori just walked you through, is to be able to pull some of that information together to authorize a short-term intensive service of crisis stabilization, someone that will be deployed to help Araceli implement the crisis safety plan, get her connected to some of those resources that were mentioned in the development of the plan and the document. And so this is simply an example of what might be included to establish the medical necessity that would be warranted in initiating something like crisis stabilization. So you see a little bit more of that clinical justification here in the clinical summary. Again, we use the CAT items to help support what we are writing in narrative form. And so this is just an example of that. DSM-5 ICD-10 diagnosis is needed in order to move forward. And then again, an LPHA signature. And so one thing I'd point out here is, when we talk about initiating crisis stabilization, is that we have it for an hour a day on a weekly basis for Araceli. This is a service in the state of Illinois that can be authorized on a weekly basis. So it's really intended to build that bridge between point of crisis and re-engagement or engagement in outpatient services. So we're excited about the ability to offer crisis stabilization in the state of Illinois. And this is simply an example of how an LPHA might authorize that service. Well, I'm going backwards here. So a little bit about our implementation efforts. Kristine mentioned, that over the past 4 or 5 months, we've really initiated new efforts around the mobile crisis response system in the state of Illinois. We have been training as part of our project as PATH on the CANs and the CAT for the last 2.5 years. But more recently, we wanted to move towards really leveraging for the first time in the state of Illinois, the idea that we now have the ability to use the CAT and to use the crisis safety plan to communicate across systems, to communicate, to our outpatient providers, that everyone's using the same tools in the state of Illinois. And so prior to us, utilizing the crisis assessment tool or the CAT in the state of Illinois, we did use the old version of the CSPI, or the Childhood Severity of Psychiatric Illness, or the CSPI. So that was a wonderful tool, but sort of lived in the vacuum of mobile crisis, and it didn't have the same level of utility of being able to communicate with the CANs, which is now being implemented statewide. So building a bit of a parallel process between how we collect information to complete the CAT and the crisis safety plan to how we now collect information to complete the CANs and then the associated treatment plan of that service in Illinois. So the new version of our CAT training that includes the integrated crisis safety plan that Lori just walked us through was launched in July of 2020. So just to be clear, we've been training on CAT certification for 2.5 years. However, we just launched a new version with the integrated safety plan here in July of 2020. Healthcare and Family Services, as part of this initiative, had sent out a provider notice to our providers in Illinois to understand the requirements of completing 4 unique services. And so those services are mobile crisis response and crisis stabilization, which are pretty policy heavy, really just making sure that we're defining the service and setting the basement floor in terms of understanding of what the services are. And then the IMCAT crisis safety planning course, which produces not just CAT certifications, so mobile crisis response providers are able to go out and provide crisis response, but also to start thinking about some of the things Lori was mentioning in terms of really thinking about how we engage a bit differently to develop crisis safety plans. And then additionally, a de-escalation course. And so the de-escalation and the CAT crisis safety plan course are both offered via live webinars currently. And so as of today, last I checked, we had just surpassed 700 individuals who've been trained on the IMCAT crisis safety planning course. With our registration, we'll surpass 1,000 individuals by the end of the month. So just a little bit of data there for you about how well we're moving forward. I've already hinted at this. I want to make sure I'm okay with time. I've already hinted at this a little bit about the primary reason we moved in this direction is to really begin to bring our systems together. The IMCANS is the bedrock and the foundation of our Medicaid services. It's what opens up our Medicaid service array to individuals who are in need. And so now the fact that we have the CAP, which communicates directly almost all of the items, not quite all, but most of the items that are on the CAP are also on our IMCANS, which is our approved integrated assessment and treatment plan tool. So the communication between point of crisis and outpatient services is significantly increased, which is incredibly exciting. Again, that communication, second bullet point there. Lori talked a little bit about individual and family preferences, the service preferences in the tool. That is also information that is collected in the CANs. And as we know, we don't always receive the same information at point of crisis than we do at an initial assessment or at a follow-up appointment after a crisis event. And so this allows for us to gather additional information, that information to communicate across systems and across tools. Those resources, those goals and objectives, that format of the goals and the action steps is the format that we use for our treatment planning. So again, it provides us an opportunity to review and revise new information that might be bubbling up at point of crisis that maybe has been missed on an outpatient level. So when we're able to directly go from point A on the CANs and point A on the CAT, it just lines up information and decreases the likelihood that individuals are going to have to continue to retell their story or that we potentially lose information in transitions. Strengths, again, Lori talked a little bit about strengths. As most of you are probably aware, the CAT does not have the strengths domain on it. Does not mean that we should not be trying to engage in helping identify and leverage resources and supports strengths at point of crisis. Again, if we are simply doing mental status evals and risk assessments, oftentimes we're not going to be able to capture the full picture of what we might be able to put into place to help stabilize an individual. We do know that there are instances which stabilization is just not feasible, due to clinical acuity, and thus we need to proceed with, facilitating inpatient hospitalization. And so that's a reality. We want to make sure that we're exhausting all resources, supports, and strengths in the conversation to ensure that we do in fact need to move to the route of hospitalization. That consistent and common language we've talked about pretty extensively, as well as the continuity of communication and care across all levels of support.
Hey, Matthew.
Yes.
We do have a question in the chat box from Barbara. She was asking about a model of mobile response and stabilization. Is there one specifically that you use? And then you might just open the chat box to see.
Yeah, I'm taking a peek at it.
Authorization, yeah.
Yeah. So is there a model of mobile response and stabilization that we use? That just varies. We have providers who provide just mobile crisis response. We have providers that provide both mobile crisis response and crisis stabilization. Kristine, you probably have a better idea than I do about, you know, the frequency of providers having both of those services in their toolkit, but I believe that it's pretty common that if someone's providing mobile crisis response, they are also able and enrolled in our system to provide crisis stabilization. And so again, crisis stabilization is just intended to help build off that and implement that crisis safety plan while we work towards a more comprehensive assessment of needs and strengths through the CANs. And so again, that stabilization in terms of a model, typically that's housed within a particular provider or entity that's providing both of these services. But the service definitions would certainly drive then how they're able to deploy that. Kristine, do you want to add anything to that?
I think you're muted.
Yeah. Or I can't hear you anyway.
The dreaded double mute.
There you go.
I was just going to agree and say, really, you know, we establish our service through our service definitions. We don't necessarily have an established model that everybody has to implement, but they do have to conform with the service definitions that we have out. Yeah.
And your second piece here, Barbara, so the crisis safety plan with the integrated CAT is completed. Then the IMCAT is completed on the other forms signed by the LPHA and submitted for the authorization. Typically what we would recommend, and again, I think that there's probably variability, Barb, around how individuals are completing the authorization, because this is simply just an example of the authorization. But typically what we'd recommend is that clinically licensed individuals reviewing the crisis safety plan, having some conversation with the mobile crisis responder. Obviously, it's been identified in Araceli's case that was something that was desirable. And so there would be a review of that crisis safety plan, a signing off of that crisis safety plan, and then that additional information would need to be signed off on by that same licensed clinician in order to initiate crisis stabilization. So hoping that answers your question.
Yeah, just the efficiency of the process. Just looking at that.
Sure. Yeah, and I think that, I mean, again, best practice I would think would, there would be an associated component, sort of an extension or an addendum to the crisis safety plan so that you have all that information right there. What we show in our training and what you just saw is just an example of the information that would be required in order to do that. And then Liliana, looks like, what happens if the consumer is unavailable for an assessment? Are you still able to bill for crisis stabilization? I suppose it would mean what you mean by assessment in terms like a comprehensive assessment of needs and strengths. We would be using crisis stabilization and authorizing that on a weekly basis. It is intended to be short term and a little bit more intensive while we build that bridge to a longer term plan through completion of the IMCANs. If we went a period of time where we were authorizing crisis stabilization because we were having difficulty engaging, or there were challenges or barriers that were preventing a consumer to get in and receive the assessment, that would open up the broader service array. Certainly we would want to discuss that. We would want to identify what those challenges are. One, is there a need for that ongoing assessment? Is there a service preference or a provider preference that we haven't identified as maybe preventing Araceli from establishing that comprehensive assessment of needs and strengths? So again, we would want to not just immediately jump to the idea that Araceli or an individual who was unavailable for an assessment was being quote unquote non-compliant. We don't love that language, but working with them to identify what were the challenges and the barriers and the perceptions that were maybe preventing Araceli from engaging in that assessment. But yes, you could still bill for crisis stabilization without the IMCANs being completed. But I would say if you did that for several weeks and we were not successful in engagement, we'd probably want to dig into what the challenges were. I know we're bumping up just a couple more minutes. Great questions. Thank you. Those are wonderful questions. We have some future forward thinking around use of the crisis safety plan as well. The state of Illinois will be implementing wraparound in the coming calendar year. And so again, the same way that we want to have the crisis safety plan and the IMCAT communicate with the IMCANs, we want that to have leverage in crisis prevention planning and wraparound. One of the struggles in Illinois, and I presume elsewhere, is working in crisis is a very reactive line of work from time to time. And so how do we turn the corner and start using some of the information that Lori just walked us through to start building out a little bit more of an understanding about how we can prevent crisis from occurring and building up preventative crisis prevention plans moving forward in the wraparound process. So that's something that we've already begun work on. Maybe we'll be presenting on that connectivity next year, but that is something that we have on our radar for development. And again, we do believe that there's an opportunity to improve outcomes for individuals, families through collaboration and shared language. And as you can see here, a lot of these are systems of care values that we are hoping to operationalize in the new work that we're doing in Illinois. And then just finally, of course, it's never Illinois if you don't have some challenges. And so we do have some challenges, of course. Again, it's really starting to push back a little bit on old lines of thinking about how we do mobile crisis response in the state of Illinois. As someone who's done crisis work in the state of Illinois for over 10 years in some capacity, I'm certainly guilty of that myself, but really being to communicate and demonstrate the cross systems value of using an integrated tool or some version of this type of integrated crisis safety plan and the CAT items. Establishing, as Lori mentioned, that MCR is one of engagement as opposed to just MSEs and risk assessments. Beginning to pull out and extract that person-centered language. And even in the instances in which we potentially land in a world where we have to hospitalize an individual or a youth, that we're beginning to think about some of the information that we would want to collect in a crisis safety plan or crisis prevention plan. Rather than just saying, oh, well, we're hospitalizing, thus we don't need a crisis prevention plan or safety plan. Well, there's valuable information there that can be helpful in the future to prevent or mitigate the likelihood of recidivism. And then, as we've heard all week, and every year we seem to have this conversation at TCOM, so I feel very validated that others experience this struggle, whether it's the CANs or the CAT, moving away from using the CAT as a checklist. Or in this instance, the crisis safety plan as a chronological document that you're just working through, rather than really focusing on the individuals that we're working with and that we're trying to support in times of need. So that certainly is a challenge, both for our IMCANs and our IMCAT implementation efforts. So I believe I am right up against the time limit here. So we probably could take a question or two, Tiffany. I don't know if that's possible. But if not, we do have our contact information here as well. So feel free to reach out.
I'll leave the room open so people can feel free to ask questions.
Okay, wonderful. I just want to thank everyone. I know it's been a long week and people are running into their Friday evening. And so just want to thank everyone for joining us today. Very much, Judith.
Oh, I do. Let me share really quickly the Mind Cans, because I know some of you are some very serious players.
Yeah. And if there's anybody on here who has 1,400 points, congratulations.
Yeah, that's amazing. And Jose, we are working towards both Spanish versions of the CANs and the CATs. We have not quite been successful on that, but that continues to be one of our biggest priorities. So to answer your question, no, we currently do not, but we are very serious about getting that out into the world very soon.
All right, there's the magic word. To those of you or whoever has 1,400 points, hats off to you. That's amazing. That's dedication. I'll keep this room open as long as you need it, so you can ask questions and engage with the presenters. But if you are going to hop off, thank you so much for joining us. You've made this an amazing conference, and you've been very gracious as we have worked through just a few technical support issues. Honestly, it's not been as, bad as we feared. We were all a little anxious to have a virtual conference this year, but hope that you found it worthy of your time and still a really meaningful way to connect. So you all take care of one another, and I'll keep the room open, but hope to see you in person next year.
Yes, yes, definitely. Thank you, Tiffany, for everything.
Hi, Barbara. Good seeing you again.
It's good seeing you again, and I'm so glad to catch up and find out how things are going since last year. That's good.
Tiffany, Jasmine's asking about the link for your evaluation. Is that something that they have been provided?
It was at the beginning.
It was at the beginning. Let me grab it up and I'll put it back in again because I have to scroll back to find it. All right, there it is. I just dropped it in the chat box. Thanks, Jasmine, for reminding me.
Jasmine, yes.
Good job, guys. I'm going to sign off. Good job.
Okay, Cassandra.
Yeah, see you guys soon.
Okay, bye-bye.
Bye-bye.
All right. Do you need anything else from us, Tiffany?
I don't think so. That was a great presentation. Thank you so much.
Yes, thanks for your help. Appreciate it.
Thank you.
Okay.
Bye.
Bye. Bye, Kristine.
Bye.
Bye.
Thank
Bye.
you. Bye.